Welcome to this research briefing from Global Affairs and Social Medicine, the first of many we hope to do across Global Affairs this year. I want to first welcome our guests to this briefing, researchers Ginevra, Ludovico and Karen. If I can invite them to introduce themselves and talk about their roles here at King's.
Yeah, so hi, I'm Ginevra Floridi, and I'm a postdoctoral research associate here at Global Health and Social Medicine. I joined KCL about a year and a half ago after doing my PhD at the London School of Economics. And I've been working here at KCL on the InCare project, which is a project related to inequality in social care from the point of view of both caregivers and care recipients. In particular, we look at differences across different care systems and also the potential effects for health and well-being. And yeah, in general, I'm interested not only in care and inequalities, but also more broadly on intergenerational exchanges between older adults and younger generations, as well as health and well-being.
Hi, everyone. Thank you very much, James. I'm Ludovico. I'm a research fellow within the department. I'm a public economist, I would say. I work on topics related to health and social policies, especially for the aging population. I focus on pension reforms, on long-term care systems in Europe, in the UK, and globally, and how, especially in general, I would say, I study how the state intervention can improve or not, depending on the cases, the welfare and the well-being of people, especially older people. And in the department, I work with Ginevra, with Karen, and other professors.
And hi, thanks so much, James. I'm Karen Glazer. So I'm a professor of gerontology here at King's. I've been here for many, many years. I'm now head of department. And as Ludovico and Ginevra have said, I'm the PI on this project. This is an open research area project that's being led by the Free University of Amsterdam. But it's also in partnership with the University of Dortmund in Germany and Keio University in Japan. And as both my colleagues have said, the key focus here is looking at inequalities in care, how kind of long-term care systems can shape these inequalities and what the implications of this might be for health and well-being.
Fantastic. So, Ginevra, if I can come to you first, the paper titled Socio-Economic Inequalities in Home Care Use Across Regional Long-Term Care Systems in Europe. Can we just start by saying, what do we mean by these terms home care and long-term care?
Yeah, so well, broadly, long-term care is the support that people who are vulnerable receive, and we mean in the sense that these are people who have some sort of physical or cognitive impairment that leads to a limitation in their daily activities. These are usually older people, and in fact, in our study, we only look at individuals aged 65 and above in Europe. And in terms of long-term care, we can distinguish between two main forms of care. There is informal care and formal care. Informal care is usually provided by family members, and across Europe, but really across the world, this is the main source of support for vulnerable adults. And formal care, on the other hand, is care provided by a formal provider or a professional carer. And this may be provided either by public services or by the state, we can say, or by the private market. The state can either provide direct services or perhaps subsidize the purchase of care services through cash or transfers. The market, on the other hand, well, individuals may be able to purchase private care on the market through direct purchases or being reimbursed by private health insurance. And this really is broadly the long-term care system and what we mean by the long-term care system. And then in the study, we specifically look at home care, which is care received by individuals in their own home. And we distinguish between, well, among three different types of home care. The first one is when only informal care. So when individuals only receive care from their family members or friends, no professional providers. The second type is the opposite. So it's only formal care. So individuals only receive care from professional providers, either public or private. And then we identify a third type of care, which is a mixed home care with individuals relying on a combination of family and professional providers. And really, our objective in this paper was to find out how socioeconomic inequalities in these three forms of regional long-term care systems.
And Ludovico, one of the things that's in this study is that it looks at regional systems, not national care systems. Why was that important to look at those regional systems instead of country by country?
Yes, James, this is part of a larger, I would say, research agenda that we have within the department with the InCare project and also with other projects that we are involved with. And the idea is that in order to understand how long-term care impacts the well-being of people, we need to understand very well the context where people live. And the crucial aspect of the access to care is that in order, for example, to access public care, you need to fulfill some rules. So it is important to understand what the rules are and what are the characteristics of the system where a specific person lives in terms of duration of a benefit, for example, the amount of a benefit, the requirements for accessing the benefits, the amount of coverage that is offered in that region. So as an alternative for family care, for example, no? This is our goal, and this is something that is usually often overlooked in the literature. Like instead of looking at broad countries, we want to look at specific regions. Why? Because most often the way in which long-term care systems are organized is a decentralized decentralized system, so that each region has some specific power in determining, for example, the supply, the availability of care, or the rules for accessing care for people. And this is important, and it's an important feature of this study as well.
And you went on to actually look at the income and financial wealth of users and the effect on their use of social care in regions with different care systems. Can you tell us a little bit more about that aspect of the study?
Yes, exactly. What we aim to do in this study, as Ginevra was also saying, is focusing on a specific feature of the care systems and how this varies across administrative regions in Europe. And this feature of the care system is the extent to which a care system offers alternatives to families for care provision outside of the house of the dependent person. So alternatives to home care in terms of availability of formal care. And we aim to study how socioeconomic characteristics of individuals, for example, income and wealth in our case, affect the probability, we call it, but let's say affect the possibility for people to access care, and how this varies across different care systems, across the different regions. And in particular, in order to define the care systems, in order to define this availability of formal care as an alternative to family care, we use the concept of bed capacity. And I think Ginevra can explain this much better than I can.
Yeah. I mean, Ludovico there, Ginevra, has mentioned about bed capacity, or what you call in the study bed capacity. Can you tell us a little bit more about that and how you actually measured it within the regional systems?
Yeah, so as Ludovico said, we were really just interested in the extent to which across regions there are alternatives to family care as a form of care provision. And so the way we measured this is through bed capacity, or specifically the number of beds in residential long-term care facilities or care homes per 1,000 inhabitants in each region. So these beds they go from 0.5 to 22 beds, to give you an idea, per 1,000 inhabitants across European regions. And these beds could be either public or private, in the sense that they could be in public nursing homes or in private care facilities. But really what a system with more beds indicates is that in that system there are more alternatives for families. Rather than just providing the care themselves, families can actually outsource the care more easily. So that's why we took it as an indicator. And also the great thing about this indicator is that it shows how much variation there is at regional level. It gives us a lot of variation, which allows us to study differences in these inequalities. And we found actually that even within the same countries, there was a high degree of variation in the number of beds. To give you an example, in Italy, the number of beds went from 0.5 in some southern regions, which is really low per 1,000 inhabitants, to 10 beds per 1,000 inhabitants, which is actually quite a bit and above the European average in some northern regions. So while some previous studies have perhaps compared countries or groups of countries, we managed to go, let's say, into more depth, into more greater depth in the characteristics of the regional long-term care system.
I mean, Karen, clearly the study broke new ground in the way that it analysed social care data. I mean, what were some of the key findings from the research?
I think the main thing is, as both my colleagues have said, is no one really looked before at the kind of the context and what difference that made to kind of the use, and especially differences by socioeconomic status in the use of care, formal and informal care. And so one thing we showed is that there had been mixed results, but you clearly see that people, regardless of the type of long-term care context, that those who are more disadvantaged are more likely to rely on families, and those who are better off are more likely to rely on services, on formal care. And that's because they have a greater ability probably to purchase this. And what our study really showed, that if you have a long-term care system that has more alternatives to family care, those who are more disadvantaged are more likely to use both family and formal services. And the opposite is true for the other way around. So fewer long-term care beds or fewer alternatives to family care, then it is the wealthier. So those who have greater advantages, socioeconomic advantages, who are more likely to use both. So it really kind of showed that there was a big difference there. So that if you had a system that provided more alternatives to family care, those who were more socioeconomically disadvantaged were more likely to use both types of care, mixed care.
And so it's fair to say it was critical to look at the ways in which wealth and income interact with social care.
Yeah, it's actually very critical to look at how the contextual level factors, so the kind of long-term care systems, interact with individual characteristics. And in this case, we were looking at income and wealth as proxies for socioeconomic status.
Fantastic. I mean, perhaps if we can come to each of you just to finish up and ask really, the research is very extensive and it's looking at the social care system. But what kinds of lessons can we take in terms of perhaps policy making, not just for the systems that it studies, but across Europe and here in the UK and around the world for the social care system? Perhaps, Ginevra, I can come to you first.
Yeah, so I think, well, across Europe and including the UK, there has generally been a move towards trying to make long-term care systems cheaper. Because of the problems associated with having greater and greater numbers of older people in the population and increasing costs. And one way to making long-term care systems cheaper has perhaps been to give more responsibilities to families in the sense that, for instance, the income threshold for means-tested services is lower, so that fewer people can access means-tested services, or just public services. So in this sense, I guess one policy implication of this research is that these trends may actually be disadvantaging poorer individuals disproportionately compared to richer individuals. And this could have potential consequences for future costs in terms of health, because, for instance, some qualitative studies have shown that receiving both formal and informal care is particularly for older people in vulnerable condition. It might be their preferred option, and lower access among lower socioeconomic groups may put them at greater disadvantage with future than higher costs for healthcare systems.
Yes, I think Ginevra is absolutely right, and I would add that from how I see it, this study fits very well into the debate that we are facing right now in the UK, with the debate over the long-term care reforms. There's been a long debate, and some reform will probably happen in the future. We don't know. The COVID crisis postponed everything, so it is very difficult now to say. But part of the debate was on two major changes, let's say, on the current social care system in the UK. One was to raise the capital limit for people in care homes. So to allow more people, in a way, to access some type of subsidy for care homes. And the second was to increase, to add actually a cap on the individual liabilities for care costs, so that we can make sure that people never pay catastrophic costs for their care. And this is, I think that our study explains why this is important, because we show that the context is crucial in determining the inequalities in access. So someone can afford and therefore will be covered, and someone else with the same needs or even worse needs in terms of dependency may not have the chance to be covered, with important implications for social exclusion, unmet needs, and ultimately health and well-being.
I think both my colleagues have said it brilliantly, that basically the context makes a huge difference, and the kind of retrenchment that we've seen and cutbacks in a lot of services, where now they're really concentrated on those with the greatest levels of disability, has meant that you do see a great reliance on families. And this is different by different socioeconomic statuses, and those who are more disadvantaged may be harmed even more by these policies. And this might have long-term consequences in terms of health and well-being. So that really has important consequences, the type of long-term care system and the services that are available.
Well, thank you all three of you for joining us for this research briefing and sharing this really important new study. Thank you.
Thank you, James.
Thank you. Thank you so much for having us.